right, good morning, everyone. Thank you for being here. My name is Kelly Andrew. I'm Coordinator of Research and Mission Programs at HDSA, and you are here today in the Cognitive Impairment and Firearms Safety and Planning talk today with Dr. Laura Prater. As a reminder, please keep a face mask covering your nose and mouth at all times during the presentation, unless you are actively eating or drinking. As a reminder, you can ask questions and interact with our speaker today in your Socio app. If you go to Agenda and open up this session, there will be a Q&A bar at the top of your page, and you can go ahead and click that bar and interact. You can ask questions anonymously or with your name and identification, whatever you're more comfortable with. And with that, I'll hand it over to our speaker.
Great, thank you so much. Just get myself situated here. Okay, well, hello everyone. Good morning. Thank you for being here. My name's Laura Prater. I'm a research assistant professor at the University of Washington in the Department of Psychiatry and Behavioral Sciences. I'm also the associate director of the Firearm Injury and Policy Research Program at the Harborview Injury Prevention and Research Center, also at the UW School of Medicine. So I'm going to start with the disclaimers. The information provided in my presentation's part of the 2022 HDSA Annual Convention, and it's for informational use only. Any recommendations or information I provide, please definitely consult with your individual healthcare providers and definitely keep them in the loop. I have no conflicts of interest to disclose that are relevant. I do have work that is funded by the National Institutes on Aging, the American Foundation for Suicide Prevention, and the National Collaborative on Gun Violence Research. Okay, so to start, I'm a firearm suicide researcher, so I develop interventions that help to prevent suicide. I focus on populations with either serious illnesses, or cognitive impairments such as dementia. And so a lot of the information I'm providing today is in the context of dementia, definitely relevant to the HD population. So in this presentation, I want to share a little bit of what I know from my research and kind of apply it to HD and firearms. And because, I'll get into this in a little bit, but because firearms are responsible for a really big proportion of suicides, that's how it's really relevant, and also relevant for HD because HD patients are at a higher risk. So the key questions I'm going to go over today, I'm going to hopefully answer what does suicide prevention have to do with firearms? How can we address suicide prevention in Huntington's disease? And how can we keep people safe from injury while also honoring their independence and right to own firearms in this country? Okay, so the agenda, I'm going to go over, to answer the questions, I'm going to go over the epidemiology, or just the broad scope of firearms and suicide. I'm going to talk a little bit about health problems and how they're a risk factor for suicide. I'm going to give some clinical, individual, and family level solutions, and then I'm going to talk about some policy solutions as well. Okay, unfortunately, yes, the version of PowerPoint I used kind of messed up my numbers a little bit, but that's okay. I wanted to talk a little bit about firearm mortality in the United States. So in this graph, you see the firearm suicide and homicide breakdown. So many people think, especially the media covers mass shootings, that those are, the greatest burden of firearm deaths in this country. And in fact, they're not. That 4% should go to that little green sliver at the bottom, which includes unintentional shootings, law enforcement shootings, and less than 1%, in fact, about 2.2% of those shootings, or of those deaths, are mass shootings. So what we don't hear about in the news a lot is that 61% of all deaths from firearms are suicides, and about a third, or 36%, are homicides. Okay, so since the majority of firearm deaths are suicides, and it's a leading cause of death for all Americans, I'm going to focus more on this issue because it's also relevant to HD community. So understanding how people die by suicide is really important, so we can work on prevention through preventing access to mechanisms. In the general public, 51% of suicide deaths are caused by a firearm. About a quarter are suffocation, and 11 drug poisoning, 12 all other methods. So obviously firearms are a really important component of suicide prevention, and even more so for HD, which I'll get into in a few slides. But First, I wanted to give a little bit more of a broad overview of suicide risk factors kind of across the lifespan. Being older, being a male, having a prior attempt, having a mood disorder such as depression, having prior exposure to violence in the form of abuse or even active military engagement, or having physical health problems or chronic or acute pain. Those are all risk factors for suicide broadly. Now, when we look specifically at firearm suicide, these folks are actually less likely to have a non-fatal attempt that might flag them as being at risk and kind of put them in the mental health care system. We know that firearms make up only 5% of all suicide attempts, but account for about 50% of deaths. And that's in large part due to the fact that firearms are very lethal. They're 80 to 90% lethal, and the 10 to 20% that survive a lot of times have great disabilities. We also know just generally that it's increasing in traditionally lower risk groups, such as Black youth and females. Okay, so why do firearms account for so many suicides? Well, in this country, it is a right to own firearms if you'd like, so many people have them. In the US, approximately 42% of individuals have a firearm or live with one in the home. And that very small graph on the right is just showing some of the common demographic groups that have high rates of firearm ownership or firearms in the home. And again, men are more likely to have them or have them in the home. White people are more likely to have them, as well as folks in rural areas. Okay. So among those who own firearms, we know, for a lot of people, it's a lifestyle. It's part of their identity, part of kind of their cultural makeup. Many people who own firearms have more than one. In fact, 80% of gun owners own more than one firearm, and I think it's about 1 in 3 own more than 5. So people own a lot of guns when they own them. The average age of initial firearm ownership is 22, so it starts very young, right around the legal age of being able to own a handgun, which is 21 in this country. And as we kind of work towards trying to stop firearm suicide, we really need to understand why people have them in the home to kind of develop suitable substitutions if, in fact, it is time for those firearms to either be passed along in a family or relinquished because someone's disease has gotten too severe to safely have them in the home. So all that said, the majority of firearm owners own them for many reasons, and these reasons can change over the life course. But the primary reason Americans say they own handguns is for protection. And the primary reason Americans say they own long guns is for sports shooting. So as we kind of look towards solutions, we need to think about, for example, if protection or safety is a major issue, what kind of substitute would make someone feel safe in their home? Would it be a security system? And then also for more social reasons, how can we make sure these people are still being able to engage in social interactions, which are so important? And in fact, social isolation is also a risk factor for suicide. So coming up with suitable solutions, meeting people where they're at, not taking away people's guns if it's unnecessary, is kind of the broad lens through which I look at suicide prevention, specifically tailored to firearms. One thing that's extremely important, and I'm going to talk about in this presentation, is that planning early before major problems happen, before there's any sort of problem, is the most effective approach. We have resources that kind of target the later ends of if planning didn't happen and it's more of an acute risk, but ideally we don't need to use those, and we focus on the early stages of planning, carrying out a plan with the person who owns the firearm, so it's not something that's just being told to them, and maintaining their independence is critical. Let me take a little sip of water here. Okay. So I wanted to shift to a very salient risk factor relevant to the HD community. So health problems, as I mentioned, are a strong risk factor for suicide. So this is going to kind of help us understand why firearm safety and suicide prevention is really relevant to the HD community. We know there's a lot of different estimates about suicide in the HD community. We know it may be up to 10 times that of the general population. It's definitely elevated. Firearms are the most common method for suicide among persons with a serious health problem. This graph on the right kind of contradicts one of the earlier slides that I showed you. It's my own data looking at methods of suicide among adults who were a little bit older but who had a serious illness. We see that firearm use increases by about 25%. So it's 76% of people with serious illnesses are actually using firearms. That's a huge increase. So we know that suicide attempts are becoming more lethal when people have serious health problems, and firearms become even more relevant. So here, this is cognitive impairment, dementia, and suicide risk. I mentioned I do a lot of research in dementia, but it's of course also relevant for HD patients and families. So I wanted to share a little bit of the evidence surrounding dementia because it's frankly stronger than the evidence surrounding HD and suicide, and there are more studies. So when we look across kind of the staging of dementia, we know that suicide risks are increased around the time of diagnosis. That evidence is pretty clear. So when someone gets a dementia diagnosis, their risk for suicide goes up. We also know mild to moderate dementia are kind of the middle stages of the disease. There's some mixed evidence around whether or not suicide goes up. And we also know when disease becomes more advanced, there's a decreased risk of suicide because people are less able to carry out detailed plans. So we know with HD, suicidal ideation and actions are elevated across all stages of the disease compared to the general public. And in fact, suicidal ideations actually increase when people begin to develop symptoms but are not yet diagnosed. And then actions and behaviors tend to increase and become more serious in terms of suicidal actions as the disease actually progresses. There's still a lot to be studied here. It's somewhat difficult to study because HD and suicide as an outcome are relatively rare, but there are some studies that suggest that kind of the time before diagnosis when symptoms are starting to appear is a risky period, and then as the disease progresses, both ideation and action tends to increase. So this is a helpful framework or model for understanding what makes people become suicidal, what moves people from having a desire to suicide to actually acting on it. And it's a little kind of busy, so I'm going to kind of go through it right now. This is Thomas Joiner's interpersonal theory of suicide. And here you see perceived burdensomeness. So when someone feels like they're a burden to their friends, family, larger community, or society, that can increase the desire for suicide. And when that overlaps with thwarted belongingness, or in other words, kind of social isolation, or someone may not feel like they belong, or that they're alone, that strengthens the desire for suicide. But not everyone who has a desire for suicide has the capability to act. And the capability to act really just is when someone can really overcome the fear of death and injury, and kind of has, that's when we think about people who may have had prior exposure to violence, or easier access to lethal mechanisms, having that capability overlap with those two components of feeling like a burden and feeling like they're alone, we often at that point would see lethal or near lethal suicide attempts. Why is this relevant to HD and people with health problems? A lot of people with serious or chronic illnesses tend to feel like they could potentially be a burden on their family, unfortunately. So this is something to consider just as a broad framework. This is a little bit random, but I think it's important to kind of include here. A lot of people, to not just focus on suicide, a lot of people worry about acts of violence in cognitive impairment as people become more serious in their course of illness. It's relatively rare, but we do have about 20% of caregivers of folks with dementia reporting that they have experienced violence from a loved one, making it even more relevant to address firearms in the home. Okay, So now that I've kind of given a broad overview of the landscape, the epidemiology around firearms suicide and health problems, I wanted to talk about how we can potentially address firearm safety using clinical, individual, and family solutions. So first, when I say clinical, I'm talking about how potentially providers can address this in clinical encounters. And when I'm talking about individuals, I'm talking about how folks can actually plan themselves for firearm safety. And then, of course, I'm going to go over some resources for family members that ideally they can partner with the actual individual who may own the firearm to work out a plan that's suitable for both. Okay, so why would we want to have healthcare providers address this in the context of, routine clinical care or specialized clinical care or even hospitalizations? So studies say that about 30% of individuals have a healthcare visit in the 7 days before they die from suicide. So that's a huge portion of people. Over half had a visit within 30 days, and this includes hospitalizations, emergency department, outpatient specialty care, and primary care. And over 90% had a visit within 1 year. So most people who die from suicide, almost all, have interaction with the healthcare system prior. So it's a definitely a high potential kind of setting for intervention. Now, I wanted to talk about kind of going through a potential clinical assessment that a provider could use with a patient and their family member. First, I wanted to talk about some of the clinical features, and this specifically relates to cognitive impairment, but you can also spread the 5 stages kind of in these 3 buckets as well. Although the symptoms would be variable based on the person and somewhat different in relation to HD. But mild cognitive impairment usually presents as mild memory loss. People are starting to have some deficits on cognitive tests. They probably can do most of the things they normally do, so they're intact ADLs or activities of daily living. But these things might require a little bit more effort. When someone has mild dementia, we're talking about more moderate memory loss. It's probably interfering with at least one activity of daily living. So maybe they're having trouble, getting dressed or something like that. In this case, with dementia, patients are aware of some deficits, but they really lack full insight to the problem. And we start to see some behavioral symptoms like hostility or delusions. When we move to the more moderate or severe stages, we're talking about severe memory loss that interferes with many activities of daily living, so more than one. So it's a greater impairment in their ability to function in their day-to-day life. Usually the person has personality and behavior changes. They might not recognize their friends and family. And this is relevant because this is based on a couple papers, but there's screening questions and assessments that we would recommend then based on these stages. So for someone with the more mild form of disease, a provider could ask if there's access to firearms in the home. And then do an assessment to see if there's any judgment or personality changes, and of course assess for depressive symptoms, because across any disease, if someone also has depression, it increases the risk for suicide. And those screening questions and assessments are the same for mild dementia. Now, the recommendations for MCI or mild cognitive impairment would be to have the person do an assessment or training by a firearm specialist, so see if they're still able to safely use their firearm at a firing range. This is where we talk about it being a good time to engage in planning, ensure safe storage, and then consider counseling the family on the transfer of the firearm if the person's presenting a suicidal risk. Similar recommendations for the mild dementia, educating and counseling the patient and family about restricted access to firearms in the home. So there's less focus on allowing the person to kind of maintain independence with their firearm, and more about either limited supervised access, but more likely kind of moving away or transitioning the person away from actively using it. Definitely ensuring safe storage is important, and also considering counseling the family on transferring the firearm if the person is becoming suicidal. Now, when we look at moderate to severe dementia, the only relevant question at that point is really to ask if the person has access to firearms in the home. At this stage, it's really important that the person does not have access to the firearms. The provider can consider the immediate risk if the patient does have access and they have any of those behavior, depressive, or personality problems. So really thinking about getting the firearm out of the home and kind of the various mechanisms I'll go over later to be able to do that. And then also working with the family and support system to ensure that the firearms are removed. Or if there's someone else in the home, making sure that the person does not have access to the safe where they are and that ammo is loaded separately from the firearm and both are locked. Okay, so these are some tools that are available to clinicians, individuals, and family caregivers. I'm not sure if these videos are going to work. I was planning to play them. I guess I can try and see what happens. But first, there's a series of online educational tools. This is the website from the center that I work at, hiprc.org, /Dementia Firearm Safety. It's currently in development, but there are a variety of educational tools up there. We're putting videos up in the coming week, and there will also be decision aids that will help walk families and the patient through making decisions about what to do with their firearm. Creating a written plan. So at firearmlifeplan.org, I worked with Dr. Emmy Betts at the University of Colorado on this project to develop a firearm life plan, which is really advanced care planning documents for firearm safety and firearm planning. And ideally, these things, they're best used very early, so even before any symptoms of the disease, but they can work later as well. And I'm going to see if this might stay really small, though, which would be a problem.
Safety, training, and preparation, protecting family and community. No matter the reason you have firearms, these ideals are shared by many responsible gun owners. And responsible ownership means planning for the future, even things we hope don't happen. Illness, medications, and even normal changes from aging can affect your ability to safely handle firearms. If you could no longer operate your firearms safely, what would you want to happen to them? Responsible ownership also means making decisions about what will happen after your death. The Firearm Life Plan was developed to help you think about these important questions and protect your family from the burden of making difficult decisions without your guidance. A Firearm Life Plan is a voluntary, personal plan made between you and those you trust. You fill the documents out yourself and share them only with those you choose. These easy-to-use documents will help you keep track of important details. The Firearm Inventory Worksheet outlines what you want done with your firearms and when. And the Legacy Map lets you share the importance of firearms in your life and preserve your memories. You can't plan for everything life throws at you, but you can plan how you respond. And again, the Firearm Life Plan documents are for you and only those you want to share them with. We don't save any of your information. A Firearm Life Plan will help you and your loved ones be prepared. Find out more at www.firearmlifeplan.org.
And this was developed with firearm owners and with members of the firearm community. And so this is a very useful tool to just kind of facilitate early planning. Basically, there's various options for safe firearm storage, some safer than others. So we talk about kind of a continuum of less safe to more safe. Obviously, the least safe would be having it in your nightstand. I know that the definition of firearm safety varies based on the person, but we're talking about firearm safety, in terms of the evidence to reduce injury. So trigger locks are something on, they're safer than nothing, and cable locks are safer than nothing, but lock boxes and especially gun safes and storing the gun separate from the ammo in safes is the safest way to actually store your firearm. When we talk about firearm transfer, we're talking about if there is an acute risk, moving it out of the house, and there is a lot of firearm policy at the state level, so it's going to vary by state as to who you can transfer it to, and I'll go into that in a few slides. Another practical solution, I wanted to talk about some conversation starters, and this is also in the Firearm Life Plan, but sometimes caregivers, it's a difficult topic to bring up, especially if you know your loved one is really wanting to hold on to their firearm. How do you even broach this topic? So there's a bunch of prompts here that are also in the Firearm Life Plan toward getting the conversation started. Just a couple examples. I know we've never talked about it, but what do you want to do with your firearms? And you might change, this is specifically for older adults, but you might change it to be relevant to your situation. And then you could also say, I've noticed your dexterity or your shaky hands are giving you trouble lately. Next time you go to the shooting range, can I go and just kind of see how you're shooting these days? There's a variety of different prompts here. You've always protected us, which is why I want to talk to you about your firearms. And you can really find the one that's kind of suitable for the specific situation. So now I want to talk a little bit more about policy, so firearm policy that's relevant here. Okay, so we know that there's a clear link between having firearm access and suicide. The evidence is clear. The study on the left is from the early 1990s, and it established a clear link between suicide and having a firearm in the home. So the suicide risk for everyone in the home increases with access to a firearm. This was replicated many times. The study on the right is the most recent. I think it was 2021 that found the exact same thing. People who owned firearms in the state of California, everyone in the home had an increased risk for suicide. So this is relevant because it has led to a variety of different policies to help protect people who are at greater risk for suicide and other vulnerable populations. First, background checks. So there's federal law on background check that requires people who purchase them through a licensed firearm dealer to go through a background check. And this is not necessarily true for private sales, but in some states it is, and I'll get to that in a minute. But so under the background check, if it were to come back that the person was one of these classes of people, they would be prohibited from purchasing it, and that's felons, fugitives, people with addiction, people who are underage, which varies based on the type of gun in some states, people who might be a danger to themselves or others, or have been involuntarily hospitalized on a mental health hold, non-citizens, people who have restraining orders, and people who have been convicted of domestic violence. And what we see, at the state level is some states have universal background checks as well, which would include private sales, and that also regulates kind of who you can transfer the gun to if there was an acute risk. So these policies are designed to protect people, but when we talk about kind of transferring the firearm out of the home, you also have to be aware of what the rules are in your state around background checks. Extreme risk protection orders, you guys have probably heard of, I call them ERPOs. The name of them varies based on the state, but they're called red flag laws. They generally have pretty good support from both ends of the political spectrum, which is why they've been effective for the most part in getting passed. So who can file an ERPO depends on the state, but always includes law enforcement officers. And what is it? It's a civil court order that prevents firearm access to certain high-risk individuals, but it's based on behaviors. It prevents people from buying new firearms, and it's ideally supposed to have people relinquish their existing firearms, but sometimes it's hard to know how many are actually in the home and get them all out of the home. The behaviors that are covered include violence, someone who's threatening self-harm or potential for suicide, actions related to a mental health crisis, and someone who is abusing alcohol or drugs. So who can file varies based on the state. that we're talking about, and 19 states have ERPO laws right now. Like I said, it always includes law enforcement officers, and that's who we see the majority of time. That's who's filing. In some states, it can be a close family member, roommate, employer, and healthcare providers, but it's pretty rare for healthcare providers to actually file these. As I mentioned, 19 states have ERPO laws. And I mean, so where it's relevant in HD is if someone gets to a point where they're in an acute crisis and not wanting to relinquish their firearm. If you're in a state that has an ERPO law, you can actually go and file one at the courthouse. 13 of the 19 states allow civilians to file them. I won't go through the list of who those states are, but you can look it up on Gifford's law database, which I have the link towards the end of our presentation. So we've evaluated these policies, and we noticed actually a trend because in the state of Washington, there is an ERPO law, and we looked at all of the ERPOs that were filed in the state of Washington since 2016 when it started. And we noticed a pattern of these being filed for people who had pretty severe dementia. And it was really evident in reading the narratives and the law enforcement reports that this was happening in the later stages of disease in the absence of kind of any sort of early planning. So the firearm was in the home beyond the point of when it was safe. So really, and you know, it was really traumatic, I will say, in a lot of those circumstances for everyone involved. Even if no one ended up getting injured, even just discharge of the firearm in the home was very stressful, and having law enforcement serve the order, things like that, it's just a lot of stress and overwhelm for everyone involved. And then this other study, we looked at civilian petitioners in the state of Washington. There weren't that many, but those that did file, they told us that the process was extremely burdensome and difficult. It required that they went to court twice. The burden of documentation was really high. That's not to say they didn't think it was effective. They thought it was effective to remove the firearm from a risky situation and maybe save the life of their loved one. We're looking at ways now to hopefully make the process more streamlined and not as difficult for people to do. Not everyone can take 2 days off of work and go down to the courthouse in their state and file these. So, but the good news is that some studies have shown early evidence that suicide risk actually declines with extreme risk protection orders. So it looks like it's a good policy. We just have to improve it, and then hopefully more states also pick it up. I did mention firearm transfer and how that is a viable option. This is in the state of Washington. Colorado also has one of these maps. This is at HIPRC website, which I mentioned before. But if you live in the state of Washington, these are all like police stations, law enforcement agencies, firearm retailers, and shooting ranges that were called and agreed to take firearms in the event of a risky situation or if there was a risk of self-harm. Now, not every state has these, as I mentioned. And this isn't legal in every state. Like I said, if there's a universal background check law, it could be that you couldn't necessarily go and just transfer your firearm to a firearm retailer. However, a lot of those states that have universal background checks have now put provisions in so you can. All that to say is that it's very confusing, and I would definitely recommend looking up the law in your state. Figuring it out, and then you could always call a shooting range, who I'm sure will be familiar with what the law is, or a police station, and ask them where you can take a firearm if you don't have one of these maps in your state, which likely, unless you live in Washington, Colorado, New Jersey, you probably don't. And again, you can look at the Gifford's Law database and the link I have at the end to kind of have a more high-level overview of what the laws are in your state around transfer. Okay, so before, it looks like I put this one, these are resources. Okay, so some of the takeaways from my presentation, suicide's the primary firearm-related risk for persons with serious illness. Firearms are the most common mechanism for suicide, and even more so for people with serious illness. Specific recommendations for firearm safety and planning are available for people with cognitive impairment, and they vary by disease stage and can be adapted to HD. Access to firearms and suicide is very strongly linked, and that has led to some policy, restrictive firearm policies that are designed not to take firearms away, but to protect vulnerable segments of the population. And it's also led to the development of practical tools that I've provided in the presentation for you all. And then certain policy tools like ERPO may help protect people in situations where there's a concerning behavior or the risk is very strong, but early planning is always better. Definitely encourage people to talk with their family members. And then firearm transfers may be legal depending on your state and warranted if someone's in a suicidal crisis. I provided some resources here. So National Suicide Prevention Lifeline, if someone's in an acute risk state, directing them, doing a warm handoff, meaning calling and handing them the phone with the National Suicide Prevention Lifeline can help a great deal. The resources I recommended for dementia and firearm safety that I've been working on and will continue to add to in the coming months are here at hiprc.org/dementia firearm safety. And then finally, the Firearm Life Plan, or the Advanced Care Planning documents for firearms. The link is here. Some other quickly resources, the 3 interventions toolkits. Also on HIPRC's website goes through safe storage, that video that I couldn't play for you today, that kind of goes a broad overview of what safe storage means, and firearm transfer. It goes through some educational materials on ERPO, and it also goes through something called a voluntary firearm waiver, which you could actually put yourself on a list in some states, to Washington being one of them, but to have it so that you wouldn't pass a background check for a limited amount of time if you're worried about yourself. And that's not been used very much. It's a newer policy, but we walk through it in the 3 interventions toolkit. Safety and dementia talks not only about firearms, but also about falls and driving, which are injury risks in any neurodegenerative condition. And Giffords Law Center, as I mentioned, it's really a user-friendly way to find what the policies are in your state. As I mentioned, most firearm policy is passed at the state level. There's only a few passed at the federal level. So this country has a variety of different policies. Definitely recommend educating yourself on those if you have a firearm. If you guys are researching, have any questions about laws in your state, please don't hesitate to email me. I'm always happy to walk through that with you. That's my email address and my Twitter. And that's it. I am happy to take any questions you all have.
All right, thank you, Dr. Prater. As a reminder, anyone can ask questions through the convention app with the Q&A section. We're using that just to make sure our online audience and our in-person audience can both ask questions together. We do have one question in the chat right now. It's a long one. Sorry. One second.
Yeah, I'm looking at it too.
Oh, great. For families with large collections of firearms, is there a responsibility of a medical provider to request removal in the at later stages of Huntington's disease?
Yes, there is not necessarily responsibility. It's definitely an evidence-based practice, and I think over time people have, or providers have, there's been some misinformation saying that they're not allowed to ask about firearms. They are allowed to ask about firearms. It's a public health issue, and they should. And many professional societies like the American Academy of Pediatrics, the American College of Physicians actually recommend that physicians do ask about that. And it could be part of, in my opinion, just standard primary care for everyone, not necessarily just for HD folks. And as someone starts to get in the later stages of disease, it hopefully would have been addressed between the person and their family much sooner, but oftentimes we know that doesn't happen. And so checking back in, regardless of the stage of disease, even if it is later, is important.
Thank you. While we wait for more questions to come in, and families with legacy gun ownership, do you have any advice for speaking with minors about gun ownership or guns in the home?
Yeah, that's a really good question. So, of course, it depends on the state you're in. If you can't have a firearm, a federal law states you can't have a firearm or a handgun if you're younger than 21, but some long guns are available in some states at the age of 18. Some states have increased that to 21. So, and then, of course, there's always reasons for accessing firearms sooner than that in very specific situations. But yes, I think talking about younger folks with firearms and asking if it's something they, would like to have in the future, talking with them about the importance it's had in your life, your legacy with that firearm, if it has sentimental value, if it has financial value, talking to them about it, and just kind of understanding if they want to receive it in the future. And then, making plans for how to safely do that so that they're not getting their hands on it before it's legal.
Thank you. A couple more questions coming through in the chat. What role does HIPAA play in this topic regarding discussions with clinicians?
So that's a really good question. I'll separate it from kind of the suicide risk piece. A clinician's not going to disclose whether or not you have a firearm to anyone outside of the encounter, unless, of course, it's kind of hard to remove, unless there's like a reason why they think, the person might be homicidal. I think that there, in some cases for mental health professionals, is some duty to warn the person. But, with HIPAA, it's a private issue. It's something, if the person's not demonstrating any risk, there's no reason to think that your firearm would be taken away because a physician's talking to you about it. It's just like driving, talking to someone about driving safety, talking to someone about fall safety. Firearm fits in with that, and I think that more and more people are wanting to work with firearm owners just to make sure they're safe, not to take the firearms away. That certainly isn't my goal in doing this research.
Do you have suggestions for providers to bring this up with patients or with concerned caregivers, especially in states where we cannot file ERPOs?
Yeah, that's a great question. So in the Firearm Life Plan, there's guidance on how to start the conversations from the perspective of the person or the family member. When we talk about providers, I think nesting it within the context of other safety issues is important because it is a safety issue, like I said, and putting it in a clinical template so that it's just routine. You're asking, do you have firearms in the home? If the answer is yes, how do you store those now? And then if they say in a way that's not very safe, or they're presenting as being depressed or having another risk factor, directing them to some of the resources that I've provided today, like the Firearm Life Plan, Safety and Dementia. If it's relevant, a warm handoff to the National Suicide Prevention Lifeline. But really just asking the question is a good way to kind of get started. You can provide, if you're not comfortable with talking through what safe storage looks like, or you're not comfortable with your competency around firearms, you can refer them to some of the videos and resources that I've provided in the presentation today to kind of do that education piece. And then following up is critically important. So the next time you're seeing that patient, asking about, did you think about your firearm storage? Have you made any plans to make it a little bit safer? Have you sat with your family and done the Firearm Life Plan? How can I help facilitate this process? For people that are demonstrating riskier behaviors with firearms and not safe storage, it's really meeting people where they're at and acknowledging that not everyone's at the same stage of readiness to make a change. but by continuing to counsel and provide education and honing in on that point of being a responsible firearm owner, which people want to be usually, I think is really critically important.
Thank you. This conversation topic came up yesterday in our firearms roundtable discussion that happened virtually, and we have another question from our audience today. Do your statistics take into account suicidality in retired service members or law enforcement officers, and do you have specific recommendations for navigating conversations with those people?
That's a really good question. So law enforcement has an elevated risk for suicide, and as do active service members. I think veterans were included in our focus groups for the Firearm Life Plan. They provided a lot of input into that tool. So starting the conversation, having them direct it, using the Firearm Life Plan, I think, at least in showing it to them and developing it with them, has proven to be an acceptable way to move forward. With law enforcement officers, it could be the same. I think using the Firearm Life Plan would be, a similar approach to kind of meeting veterans where they're at and just encouraging people to plan early. But again, there really are, those two subsets of the population are at an increased risk for suicide. So being aware early and making sure that the firearms are stored safely and then monitoring mental health is important.
Absolutely. Another question from our audience. What best practices do you recommend caregiver use in removing access to guns by people in the later stages of HD?
Yeah, that's a really good question. So 100% recommend a safe, storing your ammunition and the firearm separately. So the gun's unlocked, the ammunition's separate. They're both locked in a safe if you intend to keep it in the home. Transferring it is a good idea because we've found that a lot of people think, specifically children, but then also even other people in the home can't access the firearms when they actually can. And you may think they don't know the combination or they can't find the lock or they know more than you think they do. And that's not, people with HD are not an exception. So I think it's a good time to start thinking about removing it from the home during those stages, but definitely safe storage.
All right. Looks like our Q&A is winding down, but I will ask, you mentioned earlier there are options formal options to assess whether or not someone is able to still safely operate a firearm. Can you discuss a little bit more of those options and how people might access them?
Yeah, so what I would recommend there is calling shooting ranges and talking to, if they have any individuals there that would be able to do an assessment. I don't think many healthcare providers are going to be able to counsel individuals on that, just like they don't do a physician's not going to come out usually and do a driving assessment with you. It's got to be somebody who has the credentials to do it, and you can usually access those people, or people will know people at shooting ranges.
Thank you. Looks like our Q&A is winding down. We have about 10 minutes left if anybody wants to sneak in any last minute questions. I will ask, you use the terms guns and firearms somewhat interchangeably. Is there any specific reason you use either of those terms at a given moment?
So in the research community, the public health research community that researches guns, we use the word firearms a lot to be an all-encompassing term of all different types of firearms, and that's why we use it. We also tend to not want to use terms like gun violence, which are somewhat loaded and not necessarily accurate, and so firearm is just a more accurate term for what we're talking about.
Thank you. I'm not seeing any more questions coming in from our audience.
Yeah, and I will say, if anybody in the audience here is a firearm owner and thinks I got anything wrong, I would love to hear what I got wrong and what I can do better. And any questions you guys have after, I'm happy to stick around and talk.
Yes, hopefully you all got Laura's contact information, Dr. Prater's contact information, excuse me, when she put it up on the screen. But thank you all for joining us today. And if that concludes our Q&A, I think we can go ahead and start wrapping up.